A 6-year-old boy is brought to the emergency department with fever, lethargy, and signs of poor perfusion. His parents report that he has been febrile for the last 2 days, vomiting, and with reduced urine output. On examination, his heart rate is 160 bpm, respiratory rate is 30 breaths per minute, blood pressure is 85/40ths of a millimeter of mercury, and capillary refill is 4 seconds. He is drowsy and has cool extremities. His oxygen saturation is 95% on room air.
Question 1. What is the most likely diagnosis for this patient based on the clinical presentation?
The patient is presenting with signs of septic shock. This includes fever, lethargy, tachycardia, poor perfusion, hypotension, and decreased urine output.
Question 2. What are the 2 types of hypovolemia observed in septic shock, and which one is more common in this case?
The 2 types of hypovolemia in septic shock are absolute hypovolemia, a loss of blood volume due to fluid loss e.g., vomiting, diarrhea, or bleeding. Relative hypovolemia, redistribution of blood volume due to vasodilation, which leads to insufficient blood in the vascular space to maintain normal perfusion.
After administering an initial fluid bolus of 20 milliliters per kilogram, what should the clinician assess to determine if the patient is fluid responsive?
After an initial fluid bolus of 20 milliliters per kilograms, the clinician should assess fluid responsiveness by looking at the following parameters.
Why should fluid boluses be administered with caution in critically ill children, especially after an initial bolus?
Fluid boluses should be administered with caution because excessive fluid administration can lead to fluid overload, which can cause increased cardiac filling pressures and worsen right ventricular function, pulmonary edema, and prolonged mechanical ventilation, exacerbation of endothelial damage, and increased risk of mortality.
What is the role of vasoactive agents in managing septic shock, and when should they be considered?
Vasoactive agents, such as norepinephrine, play a crucial role in managing septic shock by restoring vascular tone and improving venous return in cases of vasodilatory shock. Mobilizing redistributed blood volume from the venous capacitance vessels to increase stressed volume.
This should be considered early, especially if the patient remains hypotensive despite initial fluid resuscitation or shows signs of fluid overload. Early initiation of vasoactive agents can reduce the need for excessive fluids and prevent complications such as fluid overload.
What are the limitations of using central venous pressure CVP to guide fluid therapy in pediatric patients?
The limitations of using CVP to guide fluid therapy include poor reflection of intravascular volume, as CVP is influenced by thoracic, pericardial, and abdominal pressures. CVP is not reliable in the presence of pulmonary vascular disease, valvular heart disease, right ventricular dysfunction. Static nature. CVP does not reliably indicate fluid responsiveness, and changes in CVP should be used as a safety endpoint rather than a target for fluid resuscitation.
What is the Frank-Starling curve, and how does it relate to fluid responsiveness?
The Frank-Starling curve describes the relationship between cardiac preload and stroke volume. On the steep portion of the curve, an increase in preload leads to a significant increase in stroke volume, indicating that the patient is fluid responsive. On the flat portion of the curve, additional fluids will not significantly increase stroke volume, indicating that the patient is fluid non-responsive. And further fluid administration could